Asha and myself will be kind of co-moderating this session. What we are planning is we're planning for a combination of, we'll kind of moderate some questions. We have a few questions, burning questions for our career panelists that we'll ask them and invite them to share about. And then we also will open up this session for Q&A so that you have a chance to ask questions. We want this to be quite informal, and we want this to be a chance to learn from our panelists. So I just invite you to bring your questions. I think that this is a forum where it's quite, like I say, informal and really an opportunity to explore what a career looks like and what sort of things, you know, some of our mentors learned along the way, and maybe some of the hard things that they learned, or some of the things that helped them to succeed. So with that, without further ado, I'm going to pass it over to you, Asha, to introduce our panelists.
Yeah, so I'm very, very excited for this panel, and I'll just go over who our panel is. So first we have Dr. Hélène Côté. She's a professor in the Department of Pathology and Laboratory Medicine at UBC, and is a member of the Women's Health Research Institute, the Center for Blood Research, and the Edwin S.H. Leon Center for Health, Aging, and UBC, sorry. She led the CARMA, that's the Child and Women Comorbidities and Markers of Age cohort from 2008 to 2018, and is currently co-lead at the British Columbia CARMA CHIWOS collaboration study, a community-based, and this is a community-based study of health aging on women living with HIV. And then the next speaker we have is Madeleine Durand. She is a general intern and ophthalmologist. She leads a research program that focuses on discovering pathways to successful aging for aging with HIV, sorry. Her main research efforts is the Canadian HIV and aging cohort study, and she's also nominated principal investigator of the RESTART trial. And then lastly, but definitely not leastly, we have Wangari Tharao. She's the director of research and programs at Women's College Hospital. Women's Health and Women's Hands. A community health center that provides primary healthcare services for African, Caribbean, Black, Latin American, and South Asian women in Toronto and the surrounding areas. She is also a recognized community-based researcher, researching health and HIV issues related to women living with HIV in Canada, who have migrated from countries with generalized HIV epidemics. Mainly Africa and the Caribbean. Her research bridges between generations, programmatic, and policy practices to optimize health and well-being of racialized women.
Awesome. Well, I mean, thank you, Asha. That is a great introduction. And also, what a breadth of expertise. Like, that's what is amazing about. So we've got a community researcher, a clinician, scientist, if I may, Madeleine. I don't know if that's what, yeah. And a basic science researcher. So we were really excited about the diversity of our panel. So I'm going to kick us off with our first question for our panel. And so I'm going to ask our panelists if you can tell us a bit about your current position and how you got to where you are today. And in no particular order, you can go in whatever order you feel comfortable.
I guess I can start. I never mind jumping into the water first. So I work at Women's Health in Women's Hands. And I have been there for the last 25 years. And I actually joined Women's Health from a request to actually help set up the HIV program. And they wanted to set an HIV program that was integrated into a broader health strategy, not a standalone program. And I guess from that time, I can track my journey from there. When they asked me to set this program, there was no, it was in the late 1999, late 1999. And at the time, there was very, very little evidence or published literature on Black women and HIV. At the time, Black women had emerged as a very important component of the HIV epidemic in Ontario. And at the time, the only data that was available was that Black women were responsible for 70%, over 70% of children who were born with HIV. That was all. So when you're asked to set a program, usually we look at existing evidence so that you can build the program. There wasn't any. So the first thing was, talking to the women. That's the only available information we would have been able to generate. So I wondered why there was no evidence. There was no information around women and HIV, leave alone Black women and HIV. And in 2000, we decided nobody's doing research with Black women. We can't let this remain the status quo. So we applied for funding for the first research project with women living, to look at Black women and HIV. So did a proposal. Remember, we've never done research before. Did a proposal. By then, there was no CIHR. You applied for money for research from Health Canada. So we applied, we were declined. We decided we are going to try a second time. So, and the second time, as advocates, everybody will tell you, my first love is advocacy. You use evidence to advocate for whatever is actually needed. So advocacy, we resubmitted the proposal with the changes that were asked. Then we wrote a letter to the Federal Minister of Health and said, this is the status. We applied for funding, we got declined. I have no idea what he did because Health Canada came back to us and told us, your project is going to be funded, but you have to have an academic researcher on the team. So remember, just Notisha, who is now a professor at U of T, applying to do research. We've never done research. So we were told you have to have somebody from academia on your team. So we came back, we talked, and we decided, who are we going to invite? Remember, we're not very familiar with the research arena. We don't know who is there. So, but there was this professor at York University who was doing a lot of research on poverty and immigrant populations. So we called him and said, you know what, this is the status. We are bringing in for your technical support. We don't want you to influence what we are going to do because we already know what we want. So he was very kind. He did the ethics application. We got ethics from York University. And of course, we started on, we undertook our research project and generated, it was the first project funded on HIV for Black women. And we actually called it the silent voices. The ones you never had, the ones who just appeared as surveillance data, but they had a voice. So we wanted to give them a voice and try to figure out how do we set up this program? So I have come a long way from that project. And along the way, of course, I met Dr. Mona Lutfi. I think we met in 2004. I met Dr. Charu Kaushik in 2006. And we actually sat together, the three of us, and started talking about where do we want to research on women and HIV to go, which direction? So that's where we started. And Mona and I actually started the first project that set research priorities for women living with HIV in Ontario. And that it was the first peer-driven program in Canada on HIV research, because we use women living with HIV to actually coordinate the project and support the data collection for the project. And from there, of course, we had GWAS. So along the way, I have had a lot of experience with research. And because I'm located within a community-based organization, my trajectory is very different from other researchers. Because when we started that one project that was funded by Health Canada, then research funding was transferred to CIHR. CIHR started asking researchers to involve community-based organizations. So, and because we are already in the water, we became a magnet for a lot of researchers, women's health, all over. So eventually we decided, we can't let other researchers determine our research direction. So we set up a research program, and with very, very clear objectives that we wanted to build evidence on racialized women and health. We wanted to generate the data we require to inform our strategic plan and our programs. But also we wanted to share that information with others who were interested in learning more about racialized women and health, and in particular HIV. So we started small, but we have really, really grown into a huge program that works with researchers across the country, that actually also involves policymakers, because remember, we are at the point of service delivery, research, and policy. So we have our feet in all these fields. So we are able to move information from one arena to the next. But the starting point was really, really difficult, because first of all, we couldn't get funding from CIHR because we didn't qualify. But we have worked some mechanisms for working with people. So that was my start, and where I am right now. I'm a researcher. I am a service provider who help develop interventions for women's health, for issues related to racialized women's health. But also, I'm very interested in policy. So my advocacy hat never gets put down. I move with all of them at the same time. So I have had a very interesting start in research, which a lot of people may not have to go through that.
Thank you so much, Wangari. What an incredible story of advocacy. And it's so incredible how much you've built over the years. So thank you for sharing that. Now, same question to Madeleine or Hélène.
Maybe I'll go. I was trained as a biochemist, and I was a lab person, and I was doing research in the field of blood coagulation. And after my PhD, I went to do my postdoctoral fellowship in the US with the hope that this would increase my chance of having a position, an academic position in Canada, because I really wanted to come back to Vancouver. And if you do your PhD and your postdoc in a given city, well, at least in Vancouver, it's very hard to get a position in the same city afterward. Like, there was kind of an unwritten rule that we don't hire our own. So I did that. And then when it was time for me to come back to Vancouver, there were no positions in my field. And so because I was now married to somebody in Vancouver, I switched my field of research, and I took a job at the BC Centre for HIV/AIDS, BC Centre for Excellence in HIV/AIDS, and I learned about HIV. I was doing very basic work, trying to understand HIV resistance, but pretty early on, people living with HIV in the hospital started dying of we didn't know why, but we suspected it was drug toxicity of the antiretroviral therapy drugs. And so I dropped everything that I was doing to try and work on that issue, and did figure out why they were getting sick and why people were dying. And it became pretty obvious to me that although 90+% of the population that was seen at the clinic in my hospital were male, though the people who were dying and were most affected were the women. And so I got interested in studying women living with HIV at that point. And there were none really at St. Paul's Hospital, or not many. So this is what led me to linked with Oak Tree Clinic, where women were seen. And that was the beginning of a very different line of work. Working with women, I got interested in the toxicity of these medications taken during pregnancy. I figure if they're so toxic they can kill people, what are they doing to an unborn child? And so that has been my line of work for many years. I won't give you the full evolution, but I went from a molecular biologist working on blood clotting protein to a leader of a community-based research study in women living with HIV and control. I'll stop here.
Thank you, Hélène. Madeleine.
That's great. Thanks, Hélène and Wangari. Thanks to the panel for inviting me. The first thing is I'm humbled to be here and very happy to be considered by my peers a clinician scientist, because I guess that's really what I wanted to be. So that's great. So I have this very traditional story of I enrolled in med school in 1999. I graduated from med school in 2004, moved from Quebec City to Montreal because I really wanted to get out of Quebec City. And then I did internal medicine. In internal medicine, my first interest was to treat people who use drugs, of which there was a very bad epidemic. It's still ongoing in Montreal. And that took me to an HIV rotation, which was not a typical thing somebody would do in internal medicine. And that's where I got la piqûre for HIV, because I fell in love with really just the people, as you know, as well as all of the scientific interest, I have to say, around HIV. I wanted to switch then and become an ID. And Daniel Rouleau, who's a senior ID in Montreal, told me, you know, we're getting the hang of this in ID. We need internists now because people will age, and as they age, they will develop comorbidities. And that sort of picked me to HIV and aging. And that's when I decided to sort of have a career as a clinician scientist, studying, really living and aging with HIV. I trained in epidemiology because I thought to do clinical science, that might be the best training I could get. I knew I didn't have the breadth of capacities to do both wet lab and clinical, so I did epidemiology, which I never regretted. And then was fortunate when I finished, when I came back from doing epidemiology in London, to meet up with the CTN and to become a CTN postdoc. And that has really been transformative. The first thing that happened to me as a CTN postdoc was to be invited to the CAC meeting, which was always on the Monday of the week of the CTN meetings. And that blew my mind away. When I saw the hands-on contribution of people living with HIV to HIV research, that's when I knew that's exactly the field I want to work in. I was comparing it to everything I see in internal medicine, like cardiology, nephrology, blah, 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 where doctors are doctors, you know, and it's kind of siloed. Not so much nowadays, but back then it really was. And that was really, for me, a revelation. I learned so much from the CAC on that day. I couldn't believe it. And then it went on, and it wasn't always easy, but I think I can say now I did manage to become a clinician scientist in HIV.
Amazing.
Thank
Go
you.
ahead, Asha.
Yeah, amazing. Thank you so much. So the next question I have is, what are some of the most significant challenges you faced early in your career? And how did you navigate that? And this can be open for anyone to answer.
Yeah, I think I can go first. I think for me, one of the biggest challenges I actually faced, and I alluded to this, is being located in a community-based setting we didn't qualify to get research funding. And it was, you had to be located within academia to get research funding. But we had, I think because of the researchers I was working with, my research partners, we were able to bypass that because we would apply for funding. The funding would go to an academic institution, and then we would have a subcontract with the institution where the funding went, and they would transfer the funds to women's health. It was almost like a trustee relationship. We first tried this with the OHTN in Ontario. We applied for a program. They agreed that the funds could flow through them and come to women's health. The interesting thing is this became an issue when research funding was transferred to CIHR, because through, as I said, when it was with Health Canada, we were able to get our initial research funding without any problem. They didn't tell us your institution doesn't qualify. I think it's CIHR which set up these boundaries of who can get research money and who cannot. The other thing for me that is quite challenging is that because I'm located, I have other responsibilities because of my role at Women's Health. My role is not only about being a community-based researcher, I am also responsible for overseeing a whole program, the community programs at Women's Health, in addition to the research programs. So, dividing my time and my responsibilities between the two, that also becomes challenging. So for a researcher located within academia, of course, they are also teaching, I would assume, but located within the community-based organization, that is always an issue because you're doing something else that is also important to your role within that setting. But after having done this for so long, what I have done is I have built a program whereby I have junior managers now who are responsible for overseeing the community programs. And then my focus still remains in research. But in terms of development of programs, that still remains my responsibility. So for a community-based researcher, you are caught in between multiple roles. I still remember the first time when I got involved in research, because I'm funded through funding from Ontario Health. Ontario Health doesn't fund Women's Health to pay me to be a researcher. Mm-hmm. It funds me to deliver programs. And I remember one time being asked, you know what, you're focusing too much on research. You need to start focusing on program delivery. So community-based organizations or researchers within community-based settings are caught between who is funding you to do the work, the work you're supposed to be doing, but then you're focusing on research. So when CIHR came up with the idea that you could actually buy time for those ones located within community-based settings so that they could participate in research, that was actually a really huge welcome strategy, because that it enables somebody like me to be able to focus on research, because I am not hired by Women's Health to support research. I'm hired by Women's Health to support a program that is delivering health to communities. So I think it's my trajectory is very different from those located within academia.
Great, thank you.
Maybe I'll go next. My challenge, after a few years in the position where I was not a postdoc. I was higher than a postdoc, but I was not an assistant professor either. I was in that murky zone where I could not supervise a graduate student, but I could supervise staff or undergraduate students. I could write grants only for some agencies, although most not. And just like you, Wangari, I was not allowed to write grants to CIHR, but I did have research I wanted to do. I had ideas. So I went to my bosses and I said, I have this problem that I need to have the status to be able to write grants and bring in money, research money. And they said, oh, don't worry, just write the grants and put my name on it. And I did that a couple of times, but it became very unsatisfactory very fast. And when I continued asking for help into getting into an assistant professor position, I was asked by my bosses, as I refused to call them mentor, I was asked why. And then I said, why? You're asking me why I want to become an academic? And then that was me. I realized at some point I had to move out of there, but that was difficult because I was confined in one city. So there was not a lot of places I could go. The HIV research community was not that large. And so I felt pretty trapped. And my husband was actually nice. He had an academic position. He had a big group, and he said he would actually move if need be. In the end, I was lucky. I took kind of a year to write a Michael Smith Scholar application, a CIHR grant, and an equipment grant, and I got all three. And then I moved.
Wow. Well done. Well done. Can I take it from there, Hélène? That's inspiring.
Yeah, for sure. Go ahead.
So one thing I want to touch upon is the terrible, daunting multitasking that sort of falls on you the moment you graduate from your postdoc position. And I have also to name the privilege I had that I was a clinician. I was trained as an internist, so I was starting my research career, but I was also starting my clinical practice, which is super stressful. Like, you don't feel confident at all when you're on your first calls. You're challenged by your trainees. It's so that's stressful. Starting your research career would need so much time that you don't have. And at the same time, I was starting my family and had multiple children in sort of short successions. What saved me on that front was really an equal distribution of tasks at home that started day one, that continues to this day, with a fantastic partner who really sees the visible and invisible tasks involved in raising a family. That saved me on the home front. What also saved me, to be 100% transparent, is that I really invested, and by invested I mean financially, in lots of help. And I hired people to help me with my children and to do the chores, and I just hired like another person. And one of the challenges I had, so that was sort of an easy go-to to help with the work-life balance for me. And I was excessively privileged because as a physician in Canada, we are paid very well, so I could hire somebody to help me at home, and I did, and that's how I pulled it through for sure. What was not as easy was how to find help in my professional life. And this is something that, as a young researcher, is really hard. And the reason it's really hard is that as you go through your residency and/or undergrad and graduate studies and PhD, you are geared to do your project and to do everything about your project. And then you come out in the world and you're supposed to do a zillion projects, and you're supposed to find help with all of these projects, and you don't know how to be helped. You don't know how to name the task that you can explain in a good way to research assistants. So research assistants are annoyed with you because you don't know how to work with them. This is something I would have appreciated more mentorship on. how can you be helped? How can you be a good, quote unquote, boss for those research associates that start working with you, for those students that start working with you? Because I know I annoyed the hell out of them by trying to, be picky about their work or do what I told them they were going to do or stuff like that. So good mentoring in human resources, I find, is really lacking. And it was very difficult for me to learn how to parcel the job I was doing and actually contract out some of it that could be contracted. And the third thing I want to say is that retrospectively, and I really wish I could have realized this prospectively as I went along, but retrospectively, maybe when I turned 40 or 38, I realized that I was a woman. And I knew I was a woman because I was assigned female sex at birth and I identify as a cisgender woman. But I realized I was a woman really when I turned 40, because retrospectively, I looked at my early career and I was looking at the early career of a sample of men that graduated and did more or less the same as I did in the same research center with the same things, with the same means. And I realized that I really did get extra roadblocks. And I went back and looked at all those meetings when I was meeting with, all of the chiefs. So chief of university, chief of hospital, chief of research center. And the way they would speak to me, the way they would not listen to me, the way they would suggest a chain of career to me, even though I was showing them I'm doing HIV and aging, I got that grant, I got my clinician researcher salary award, and they're like, oh, HIV, well, not much money in that. Why don't you do Hep C again? Right? I could never understand why people spoke to me that way. And in hindsight, I realized they were speaking to me that way because I was a woman. And unfortunately, there were lots of missed opportunities in my early career to push back against this because I did not recognize it. I recognized it in hindsight, and I thought, I should have named it. I should have named it, I should have identified it, and I should have pushed back against it. But I wasn't prepared, and I wasn't mentored in this, and I guess it wasn't discussed so much at the time either. So I try to do better now. I try to coach people in recognizing whatever treatment they're getting because of who they are. And it doesn't have to be women, right? It can be any other characteristics. But I have to recognize that the playing field is not level. And I think that if we recognize it prospectively, so as we go, it gives us more chances. So that was a big, big roadblock for me.
That's so interesting because I I had a very similar feeling. The environment where I was before I got my position at UBC, it became clear to me that all the bosses were men, all the doers were women. Like the ones who wrote the grant, the one who ran the research, the one who did everything were the women. And there was a very low ceiling for us. And in fact, it became crystal clear when not me, but another clinician scientist at the center wrote a grant to CIHR. And one of the comments she got back was, there's never been an independent researcher, I don't know if they said female, but researcher coming out of the center. So why should we give money? and then I realized it's not just us feeling this way, it's recognized by Canadian reviewers. And so it became clear that it was not the most conducive environment for an academic career.
Yeah, the other piece is also that, listening to the two of you, there is also the issue of, and this is not just me located within a community-based research organization. It is even Black researchers within academia. It's been really difficult for them to get research funding. And part of it is, the way the research funding is actually done, the model is usually it's based on, who ranks the highest. And usually it is those old male traditional researchers that actually keep on getting the money, so that the people who are in the new researchers who are emerging at a disadvantage. And because of the systemic issues, Indigenous and Black researchers are actually their disadvantage is actually compounded.
Yes.
So even getting that research money, and we are starting to advocate now for a research model from research funding bodies that recognizes that there is this disadvantage for different levels of researchers to be able to equalize the level playing field, because you will end up having these existing gaps continue unless something is actually done.
Yeah, and the thing is that it's when it's early in your career, if you're asked to serve on a grant review panel, you may feel like you don't have much time or much expertise, but it's key to be there to actually serve on those panels so that you can advocate and you can fight for the project that you believe in and that maybe the good old club would not have gone for.
I really agree with that. I really agree. It's important to be in the.
Mona, do you have anything to say?
Thank you so much, Wangari, Hélène, Madeleine. It's amazing to hear people's stories. You know, I did my Mark Wainberg lecture like on this topic. And because I just wanted like to put a word to it, like what Madeleine was describing. It's gaslighting. You know, to go into, like, Liz, you experienced it too.
I know, I was going to tell my story, but there were so many. Yeah.
And it's unbelievable. Like, it is better. Like, we have to say that. But what's hard with gaslighting is you have to actually figure it out because they're fooling you. They're making you feel that the problem is you. And you're kind of like, you feel like something's wrong, but you don't know what it is. And then so it takes you time to process it and then to actually say, no, you know, that is wrong. And that is patriarchy and that is misogyny. And I am good at this. And this is what I'm going to do. So Madeleine, like, you shouldn't like put yourself down because you actually didn't know. You were being gaslit. And it's only until it's just recently that we've woken up to that we actually were being gaslit. We had bought in, we didn't know there was any other way than this patriarchal system. And like we do have to fight it, but like I'll tell you, I was at a U of T senior promotion committee meeting yesterday, and I stood up and advocated for a younger like woman researcher, against a like older man. I did it. I won.
I'm sure you did.
But and I can do it now, neurologically regulated, which is so much better, But that man researcher is the VP of research, is the vice chair of research, Department of Medicine, U of T, sits on the Department of Medicine Merit Award Committee that reviews me. And then, so now I went against him and like he decides if I get a merit award, like that's a problem.
It is dangerous. Yeah. It is dangerous because it annoys people when you step up and it puts you in a vulnerable position down the line.
So yeah, but it is better though. Like there's all the, maybe early career researchers, trainees, and it's like so depressing. But
well, if I can chime into that, I think that's what's the way to survive this better is to actually see the dynamics, be able to name them. And when you name them to your superiors, be they a crew of white old males, they are not in favor of this. They will remediate. So the difficult thing is to recognize. So Gender bias is rampant. Unconscious biases are rampant. I say gender because I'm a woman. That's the one I've lived. But definitely, if you come from a racialized community, it's compounded. If you're sick, if you're handicapped, anyways, many of them. So there should be this survival kit that can informally be passed around people to recognize. So gaslighting is one. The academic dishes is another one. There's so many academic dishes. Those are tasks that will be time consuming, are needed to be done just like the dishes, or else the house will get stinky and will get nowhere on your CV or in your promotion. You need to name what will happen is that your chair of division will ask you to shower you with compliments. Madeleine, the trainees love you. We trust your judgment. You're so great. Could you please do the midterm evaluations of all the medical students that go through internal medicine at your 200 a year? You need to sit with each of them and, discuss because they love your contact. This is the academic dishes. Never you will be asked to do them, especially if you are women, because everybody knows women are good at doing dishes because we don't like stinky houses. So name them to your chair. Say, oh, I would love to do this, but I thought you wanted me to be a clinician researcher, in which case this is predatory on my time and would lead your department not so well further down the line. And when you actually name this to your bosses, they start understanding. But you need to see it. You need to not buy into the initial compliments that these things come with. And there's many academic dishes. And it has been demonstrated time and again that women are asked to do more than men, and definitely pot them out. Giving whatever class 101 is academic dishes. Giving a lecture on your latest scientific research, which you already have all the slides done, is not academic dishes. It's a chance to shine. So accept those, but don't accept the 101 lectures.
Yeah.
Madeleine, thank you so much for putting a name to that. I will never forget academic dishes. And I have been experiencing too many dishes in my kitchen. And so anyway, thank you